Good morning, everyone. My name is Razia Mahmoudsadeh, and I'm one of the Retina Research Fellows. I'll be presenting today's imaging conference. Our first case is a 4-year-old boy referred for a baseline retinal examination. Dr. Shahlai, would you please walk us through these images?
Of course. So we have a color fundus photo, sounds like maybe an EUA photo of the right eye. The media appears clear. The optic disc has a very distinct clear margin appearance to it, an ample rim here. The retinal vasculature, which we're mostly seeing the posterior poles, seem to have a normal course and caliber, maybe a little bit tortuous, but not too bad as far as the extent that we can see here. And our attention here is drawn to this temporal lesion here, hypopigmented with some redness to it. It kind of looks like almost retinal exudates and intraretinal or preretinal hemorrhage. Could be also a little bit of a tractional component to it as well, hard to say. That would be the pertinent findings in this photo.
Okay.
And now we have more of a temporal sweep in the same eye, kind of see that lesion we were noticing before, but more prominently, we can see that there's clear pruning of the retinal vasculature, kind of a distinct border of avascularity that we can appreciate here, along with a loop of sclerotic vessel that we see here, maybe some microvascular abnormalities, difficult to say if they're aneurysm, telangiectatic vessels, maybe even some hemorrhage, but clearly abnormal here in the temporal retina.
Great.
Same imaging modality of the left eye, again, mostly the posterior pole. We're seeing the vasculature seem to have a relatively normal course and caliber. I don't see any macular abnormalities. The optic disc looks okay. And as far as the visualized periphery is concerned, I don't see any distinct abnormalities in this eye. Have a fluorescein angiogram at 28 seconds. Looks like the veins have been completely filled at this time frame. Our attention is drawn to this area of clear avascularity in the temporal retina. Along with at the border, we see these kind of microaneurysmal telangiectatic changes to the vasculature, some loop formation, AV anastomosis here. There's some hypofluorescence corresponding to that white-red lesion we had at this time frame, might be due to blockage. And then a little bit more of an inferior sweep showing the extent of the avascularity going inferiorly. Once again, these microvascular changes and abnormalities in the interface of that.
Dr. Shali, do you want to comment on the presence or absence of retinal dragging?
Yeah, so that's a good point. I don't really appreciate much in terms of retinal dragging per se.
And this is the latest frame we had.
The latest frame that we have. So 2 minutes, 51 seconds. There's a little bit of microvascular leakage we can see here. Otherwise, no macular leakage, no changes to the disc. And as Dr. Shields alluded to, not much in terms of dragging.
The left eye.
Oh, interesting. In the left eye, 1 minute, 51 seconds, we also appreciate some avascularity in the temporal retina on this side as well. Also some microaneurysm, possibly telangiectatic vessels here in the temporal retina, microvascular abnormalities. No distinct hyperfluorescence pattern, at least as of now. And then at late frame, 3 minute, 48 seconds, we don't really appreciate as much in terms of hyperfluorescence and leakage as we were seeing in the fellow eye. We have an horizontal OCT through the right fovea. The infrared image looks relatively unremarkable. On the B scan itself, we have a pretty good foveal contour. Don't really see much of that preservation of the inner retinal layers. One thing that we will be looking for in such a patient. The choroid seems to have a normal architecture and thickness to it overall. And the pertinent positive that we have here is these hyperreflective spots in the temporal macula. We see it at the level of the internuclear interplexiform layer, just given the appearance we were seeing on the clinical scan, may be consistent with exudates. The optic nerve and nerve fiber layer look okay.
Great.
Similar imaging modality in the left eye. It's a little bit more attenuated here. Don't really see the infrared that much, but essentially normal architecture here. Foveal contour is normal. Choroid looks normal. No media opacity. It looks optically clear overall. Unremarkable scan on this side.
What brought him in for examination initially?
Excuse me?
What brought him in for an exam initially?
So it was just referred from the other doctor for baseline retinal examination, and
But
I'll
what-
tell more history later.
Okay.
So, okay, great. So seeing all those images, what are the differential diagnoses at this point?
Yeah, so we have a young patient with bilateral peripheral non-perfusion, some evidence of an exudative retinopathy, at least in the right eye. So a few distinct entities come to mind in this age range. One of them is ROP, so I would want to know a little bit about the patient's birth history, any supplemental oxygen use, especially early on. Along the same lines, fever would be on my differential. Want to know a little more about the patient's family history, any retinal issues, any exudative retinopathy that's known in the family. Something like Norrie's disease could cause an exudative retinopathy like this. For that, I would look for any corneal abnormalities or opacities, microphthalmia or developmental delay. Incontinentia pigmenti could cause a phenotype like this, though this patient's a male and it's lethal in males unless they're an XXY. But skin changes would be characteristic for that diagnosis. Something like dyskeratosis congenita could cause a phenotype similar to this. For that, I would look at the skin, the nails, and mucosal surfaces for changes characteristic of that disease. Other things, Coates disease, atypical for it to be so bilateral like that with so much avascular involvement in both eyes, but a Coates-like disease could be on the differential here. And then sickle cell, the patient's fairly young, but sickle cell disease could cause peripheral non-perfusion. I would want to know about the patient's ethnicity and a little bit more about the medical history for that.
Another one you might consider is a muscular dystrophy, FSHD. And the family will give a history that the baby doesn't suck well and the baby drools a lot and has a flat facies, and they can have peripheral non-perfusion.
So we also had the same list of differential diagnoses. Familial exudative retroretinopathy was high on our list, and then Coates disease. But as you said, it's rarely bilateral retinopathy of prematurity, sickle cell, dyskeratosis congenita, and some retinal vascular disorders like retinal cavernous hemangioma, macroaneurysm, or hemangioblastoma. So a little bit about history. He was actually referred for baseline retinal examination because he was just diagnosed with aplastic anemia, and he was scheduled for bone marrow transplant.
So the answer is probably right there in front of you,
Yeah,
right there in front of you.
exactly. So the family history was non-contributory, and he was Caucasian and was born full term. So what would you do for the next step at this point?
Yeah, so given that history, just completing the physical exam, looking for other manifestations of dyskeratosis congenita, looking at the nails, the skin, and the mucosal surfaces.
Exactly. So we looked at the nails, and there was nail dystrophy in both hands and also feet. Also, there was some tooth dystrophy, but we don't have the pictures. So the next step would be genetic testing, and we performed the genetic testing, and TNF2 mutation, arginine was replaced by glycine was positive. So with having this mutation, we made the dyskeratosis congenita diagnosis. So speaking about dyskeratosis congenita, it was derived after the description of two brothers with nail dystrophy, oral leukoplakia, and skin pigmentation in 1910. Then there was a longer name, but fortunately now it's just dyskeratosis congenita. And early reports focused on the skin changes. So the classic triad is dystrophic fingernails, usually by 6 years, lacy reticular pigmentation on the neck and upper chest, usually shown up to 8 years, and oral leukoplakia, usually up to 7. So it's a rare illness, and incidence is 1 in 1 million. And this is a premature aging syndrome with short telomeres. And the short telomere can activate the DNA repair pathways, and only a total of 400 families worldwide are known with this syndrome. So just a refresher about telomeres, they're structures at the end of the DNA, and there's a tag repeats at the end of the telomeres, and the longest telomere length is at the beginning of the birth, and gradually it diminishes with the age. And if there's a short telomere, it activates a control point, and then we will have apoptosis. So telomerase enzyme is the good enzyme helping to just remain the telomere length. And there's a complex called sheltrin. Actually, it helps telomerase to add these tag repetitions at the end of the DNA. And any problem in these proteins would result in short telomere. So here you can see the red proteins, and these are the common mutations that can be found in this dyskeratosis congenita. So it can be inherited autosomal recessive, dominant, X-linked recessive, or as de novo mutations. Our patient had TINF2 gene mutation. This is one of the proteins in sheltrin complex, and sheltrin actually accumulates along the telomere and holds it and forms the T loops. So tissues like skin, blood, and nail, they're really highly renewable, so they're mostly affected in this syndrome. But this is just the tip of the iceberg. Other systems and organs are affected as well. So starting from hair, and then there's the chance of SCC in oral cavity and leukoplakia, and pigmentary changes on the skin. Lungs might have fibrosis, cirrhosis in the liver, SCC in the intestine, and then bone marrow failure. So I'll show 3 cases by our attending. All those 3 cases were referred with another diagnosis other than dyskeratosis congenita, masquerading that, but then the final diagnosis was dyskeratosis congenita. 11-year-old boy had unilateral visual decrease and no family history, and it was unilateral. You see the RVO exudates, and then peripheral non-perfusion. And the referral and the first diagnosis was Coats disease. And then he had dystrophy and pigmentary change. And then Dr. Shields and colleagues just noticed that there is some these changes in the skin, and there is some sort of bone marrow failure symptoms. So 1 year later, the other eye also developed some mild retinal changes, and the DKC1 mutation was positive in this patient. So it was referred for Coats disease, but actually it was DKC. The other one with, by Dr. Pulido, this is a family with autosomal dominant dyskeratosis congenita, 19-year-old male, presented with retinal edema and peripheral retinal ischemia. So here you see the edema in the left eye. And there is some peripheral non-perfusion in the left eye and vascular changes. So this patient also had pancytopenia and then early signs of bone marrow failure. The patient's 25-year-old sister and also his father had the DKC. And the last case series by Dr. Yonekawa, a brother and sister, brother 4 and sister 2, they were diagnosed with exudative retinopathy, familial exudative vitreoretinopathy, and they were also treated with laser. It is the initial presentation for the boy. The left eye actually has more striking findings, subretinal fluid with subretinal exudation and involving the macula. And this is the post-treatment. You can see the laser spot, and there's also a falciform fold in the left eye. And then these are the images for the sister. You can see it's milder, and there's just non-perfusion in the periphery, both eyes.
Again, you know, not much dragging.
Yes, exactly. And the interesting thing is that these are the pictures from father, and there's only vascular tortuosity, and there's no other finding. So 8 years after the initial diagnosis, both siblings developed pancytopenia, and there was a missense mutation in reverse transcriptase. So it shows that it's really important to obtain complete blood count from all those patients that are presenting with these symptoms. So retinal abnormalities are usually seen in only 20% of the cases. It can be just granular RPE change, macular edema, as was shown, proliferative vitreoretinopathy, only hemorrhage, TRD, nerve fiber layer infarction, pararetinal fibrosis, or optic atrophy. So it's really important. If you see CMV retinitis, it can be due to immunosuppression caused by immunosuppression from the bone marrow failure. So there's a syndrome called Revesz syndrome, and it is actually a rare and severe variant of DKC. They have the same mutation, and this is a de novo mutation. So all those green signs are really compatible with our patient. So they usually have nail dystrophy. The typical skin pigmentation change and leukoplakia are less frequent, as was in our case. Bone marrow failure usually occurs at younger ages, and it's usually seen by the second year of life, and all of them are diagnosed before 6. And they have retinal findings as well. The only thing that's different with our case, they usually have central nervous system involvement, but our patient has no central nervous system after follow-up. So I was wondering if we can call this patient just having a Revesz syndrome or not.
Hey, great case, nice presentation. So in my previous job, I saw a lot of these patients, and previously we thought that these kids got retinopathy like a fifth of the time. But once we started everyone screening with wide field angiography, the vast majority of patients have retinal findings. And so I think Revesz syndrome, this was a great observation, but it may be a misnomer. It's not, just a very small subtype of DC kids who get an exudative retinopathy. It's the vast majority. And so I think we should be calling it something else, probably like dyskeratosis congenital retinopathy, where everyone is expected to have some level of retinopathy if you look carefully enough. But again, like you mentioned, there's this phenomenon of genetic anticipation, where after each generation, the phenotype gets worse and worse. And it's a condition that we're learning more and more about. And the bone marrow transplantation is really helping these kids, because the mortality rate has historically been really high because of that. But with bone marrow transplantation, treating the aplastic anemia, they live longer. But then we're realizing that they develop other complications, including the retina issues. The pulmonary fibrosis can kill these kids. And the GI issues, we're learning more about the past couple of years, where it's you just get this kind of oozing from microbleeds constantly, but also you can develop expulsive like hemorrhages out of nowhere. And that can kill kids too a little bit in older age. So they have to have good eye care, pulmonary care, and GI care.
Yes.
That was a great presentation. I want to echo what Dr. Yanakawa said, that in some of the families' genetic anticipation is important, because the reason that it occurs and the genetic anticipation means that the next generation is worse than the prior generation, and that was in our case or our family, is because the telomeres decrease with each generation. And so that's something important to always go back and look backwards to the prior generations.
Yeah, I'd like to say excellent presentation too. For the fellows, when you see bilateral Coates disease, you've got to keep in your differential diagnosis telomere shortening diseases. And there's a whole host of these, one of which is dyskeratosis congenita, and a more severe form, Revesz syndrome, and another more severe form, Coates plus syndrome, where they have a different mutation, the CTC1 mutation, and they have short stature and premature graying of the hair and similar risks for bone marrow failure. So when you see what looks like FEVR, just keep in the back of your head, could this be a telomere shortening condition?
And when you look at the fluorescein, maybe you can just go to the fluorescein there, that nice segue. The FA is a great way to distinguish between the main things you think of when you have a child with non-perfusions: fever, ROP, coats, like you mentioned. And the fluorescein really helps to distinguish between these. And if you just look at the fluorescein pattern with the telangiectasia and aneurysms, that looks like Coates disease. But the thing that doesn't make it Coates is that one, you have hemorrhage there. You don't really get hemorrhages in Coates. And you also, on fundoscopy, you saw the sclerotic vessel. You don't get sclerosis in Coates either. You don't see that in fever either, or ROP, because those are developmental issues where the vessels never made it out there in the first place. So you can't sclerose any vessels in the periphery. And it's more consistent with something vaso-obliterative like here or sickle cell. And here, the thing that doesn't make it Coates either is that it's a very bilateral. You can get bilateral Coates in regular Coates that's not syndromic, but it tends to be very, the fellow eye findings are very mild. Here, it's pretty extensive.
Yes, exactly. So thank you, everyone. What would be the best management for this boy just before doing the bone marrow transplant?
So we don't have too much longitudinal data in terms of big studies, but we do have a lot of case reports, and we have varying presentations. And we do have cases where patients presented with, vitreous hemorrhage and tractional detachments, some published, some not. And so presumably this can progress. And if you have, avascular retina leakage, these conditions tend to progress. We don't know at what tempo, at what point, but here, this is a red cam image under anesthesia, the kid's asleep, and the child's going to have a lot of medical issues and procedures coming up. You don't know when you're going to be able to do this again. I think it's reasonable to do a prophylactic peripheral laser to the avascular retina. And here, in this case, that temporal area, there's a little bit of traction already.
Yes.
So Dr. Yonekawa, in this patient, it sounds like they were known to have an established diagnosis of at least aplastic anemia. If you were to see this patient for the first time without a diagnosis and with those findings, do you typically get like a CBC, or do you tend to direct them straight to like a pediatrician?
Good point. So I don't get CBCs on every, patient with fever or Coates, and usually these kids with a dyskeratosis with this severe of a phenotype have obvious systemic findings. But I don't do a full physical exam, but I ask the parents about the history, and you could kind of look at the child for these things. But I wouldn't get a routine CBC.
In the few cases that we've seen, they usually come in with a history of, their pediatrician noticing the spots on their skin or their nail problem. So it's not that hard to establish the diagnosis.
Okay, so we did the laser, and these are the images after 3 years. So this is the fundus photo, more peripheral, and FA shows that everything is stable. There's no leakage or new lesion, and the left eye as well. Everything looks stable. So what are the screening measures? So as everyone pointed out, these patients are at very high risk of SCC, and frequent monitoring of patients for early detection of these complications is very important. So monthly self-examination is recommended, as well as twice yearly complete CBC, annual screening by a head and neck specialist, and annually by a dentist, annual bone marrow aspirate biopsies and cytogenetics, annual liver ultrasound, and annual pulmonary function test and skin cancer screening. So moving to the next case. Yes.
We need to put eye exams in here too.
Yeah.
So that patient had the bone marrow transplant?
Yeah, after that.
What is the impact of the bone marrow transplant on the non-ocular manifestations of the disease?
So I think actually they're doing that because patient had pancytopenia, and they're doing that for that. But I think it's not, the nail dystrophy or other things are not reversible by doing the bone marrow transplant.
There's still a progression of disease, but whether that changes the tempo, I'm not sure.
Yeah, I don't think it changes the tempo, but it's an interesting thought because of the mesenchymal stem cells that come in the bone marrow. So, it's a great point.
And in these patients, when we're treating with laser, I presume we're treating similar to how we treat, you know, sickle cell with areas of non-perfusion. So we're just treating those areas that are non-perfused. It's not like a diabetic peripheral PRP situation.
Correct. You leave the intact vasculature intact and just the avascular retina. I wouldn't do it as confluent as or hot like you do for ROP. I wouldn't say hot for ROP, like medium. Probably like how you treat fever. The difference with sickle cell is that some of us for sickle cell, we apply some laser posterior to areas of neovascularization. I don't think that's really necessary here, but again, we don't really know too much yet.
Okay, thank you. Moving to the next case. 50-year-old female referred for evaluation of sudden blurred vision in the right eye since 3 weeks ago. Dr. Sivalingam, would you please explain what you see in this picture?
Yeah, happy to. So this is a wide field pseudocolor fundus photo of the right eye. Visual acuity is severely decreased at hand motions. Media looks clear. Looking at the disc margin, it looks sharp. There's a normal cup to disc ratio. The vasculature, at least superiorly, looks normal in the visualized superior periphery. But obviously our attention is drawn to this large dome-shaped elevation that does involve the central macula, explaining the hand motions vision. So there's this very well circumscribed round, looks like subretinal mass because we can see kind of good preservation of the retinal vasculature overlying it. And then adjacent, we do see what looks like some subretinal fluid that looks like it's going up even to like the 1 to 2 o'clock meridian because we can see kind of loss of the underlying choroidal vasculature. And then it even comes up here to the temporal periphery, probably up to 9, 10 o'clock. And then we see these kind of overlying retinal folds kind of adjacent to this large mass. I don't see any hemorrhages or any exudates. Yeah, it looks okay. And then here we have the left, same imaging modality in the left eye. Visual acuity is well preserved at 20/25. Media looks clear. Disc margin looks sharp. Overall vasculature looks normal. We do see this kind of hyperpigmented lesion along the inferior, just outside of the inferior arcade, with some overlying drusen, could be a nevus. It doesn't look elevated. I don't see any subretinal fluid. And then the visualized periphery looks normal. I don't know if these are just kind of pigmentary changes out here, but overall looks pretty good.
I would agree with that. The one comment I'd like to make is the choroid looks a little bit dark. This is not melanocytosis, but it's probably a person with brown irides, which is a little bit unusual. You would expect the choroid to look lighter.
And the question that I have is, go back to the right. So this is an optos, and it looks like it's a pigmented lesion. But is it a pigmented lesion? Because with optos, because you're just using green and infrared, you're getting pseudo color, and what looks like a pigmented lesion sometimes is totally amelanotic. And it's just because green is refracted more than the red.
Yeah, in the real examination, it was pigmented, but not very evident, but it was pigmented. Good point. And then the next imaging modality.
Yeah, so we have an autofluorescence image of the right eye. I think this highlights nicely where there's likely subretinal fluid, or at least maybe old subretinal fluid that has regressed. We see kind of this hyperfluorescent pattern going up to the 2 o'clock meridian, and then here probably the 10, 11 o'clock meridian. And then we see this large, round, well circumscribed area of hypoautofluorescence correlating to that round dome-shaped mass.
With Mira, the autofluorescence is really helpful in identifying the extent of subretinal fluid. You know, it's just not important for looking for orange pigment, but we use it to look for subretinal fluid.
Exactly. And the left eye.
Yeah, in the left eye, overall normal hyper and hypoautofluorescent pattern of the posterior pole. Just looking at that area where we saw that nevus, I believe it was around here. And we see some kind of punctate scattered hyperfluorescent spots correlating to the drusen. And here we have IVFA of the right eye at 40 seconds. We're in full AV phase. The disc overall looks normal. I don't see any, drastic hypoautofluorescent signal. You can see this interesting kind of radial streak-like area of hypofluorescence, possibly correlating to the border of the subretinal fluid, kind of here temporally and nasally. And then looking at the vasculature overlying this mass, I mean, there's a lot of distortion, and I'm guessing that's just from kind of the mass effect. It's hard to say whether this is true kind of delayed filling or non-perfusion, or whether this is just distortion from the mass itself. Maybe, we'll see how it looks in later frames, maybe some early kind of microvascular leakage. But the other areas of the visualized periphery look relatively normal.
Just to make one point too, right here, this vessel is a little bothersome. Because if we're saying this is a mass deep to the retina, maybe in the choroid, there should be no retinal vessels feeding into it or draining it, except rarely you can see a draining retinal vein in an eye with a melanoma. So if there's retinal invasion, breakthrough Brooks and retinal invasion of a melanoma, you can get a draining vein. So let's follow this. I think this is a vein. Let's follow that.
That's a great point.
Yeah, so here we are at minute and 27 seconds. This, I believe, is that vessel you were talking about, Dr. Shields. So what would we be looking for if we're calling it a draining retinal vein?
Yeah, to me, it looks like a draining vein. So it'd be interesting to look at the OCT and see if there's retinal infiltration at that site where this might be draining this deep mass. It doesn't impact the patient's outcome that we know of.
Yeah, and then kind of areas adjacent to the mass, we kind of see this diffuse kind of microvascular leakage in the areas of likely subretinal fluid.
And this is kind of how we differentiate melanoma from RPE adenoma. RPE adenoma usually has a prominent dilated feeding artery and a draining vein, whereas melanoma has neither, except possibly rarely a draining vein, never a feeding artery.
Thank you.
And here we are at a later frame, 5 minutes and 40 seconds. Again, kind of this diffuse microvascular leakage overlying the mass. And again, we see this kind of persistent streak-like radial pattern of hypofluorescence at the border of the subretinal fluid. And 1 minute and 23 seconds in the left eye. It looks normal to me. Here we have where the nevus was, these punctate areas of hyperfluorescence.
Later frame for left eye.
Yeah, and then the late frame looks normal.
Okay.
And here we have an ICG image of the right eye at at 52 seconds. We see good choroidal fill superiorly. Then looking at this area of the mass, kind of there's this large area of hypofluorescence. I don't see any, internal vessels per se lighting up here. I think this looks like a retinal vessel kind of overlying. Dr. Shields, if this is some type of melanoma, would you expect to see a specific pattern on ICG? Do you find ICG helpful at all in these situations, or?
Not all that helpful, but we would expect to see a little bit of what we call double circulation, intrinsic vascularity within the mass. But sometimes when it's elevated, it's so out of focus, you're not getting a good image of it. I think the best team in the world for doing ICG of choroidal melanomas at Jules Gonan. It's Zagrafis and Schallenberg. They have beautiful wide-angle images showing at multiple layers the internal vascularity within melanoma. Here, if you're just focusing on the retina, this may be so out of focus, it's not picking up in the image.
Yeah, and then a later frame, 2 minutes and 42 seconds, similar pattern, kind of this large area of hypofluorescence. And then 2 minutes and 16 seconds in the left eye, overall good choroidal fill here. We see this area of hypofluorescence correlating to that choroidal nevus. And then here we have a vertical cut OCT of the right eye, slicing right through that border of the mass. This looks like it's over the macula. And we see this large dramatic elevation of the retina with a large area of subretinal fluid. Looking at, if we're trying to tell temporal timeline here, one could argue that, maybe there is a little bit of chronicity indicated by a little bit of shagginess to these photoreceptors, although I don't know if that's just shadowing artifact from these hyperreflective foci in the vitreous, but overall kind of a degraded image secondary to this large mass. And then on the IR, you can obviously see this large hypo-reflective area correlating to the mass. And then here we have a vertical cut of the left eye. Looks normal. Vitreous is clear. We can see the hyaloids down, good inner and outer retinal laminations, and choroid looks normal.
So what's your next step?
Yeah, I think a B scan would be helpful just to see kind of what the echogenicity pattern is of this,
Yes,
of
exactly.
this mass.
So we perform.
Yeah,
a
this is a
scan.
great image. So this is a B scan ultrasound image, I'm presuming is the right eye. We see this large mushroom-shaped mass. We can see the retina is kind of draping over this mass. Overall, kind of has this hyperechoic pattern down below at the base of the lesion. It does look a little bit hypoechoic. And then, looking at the A scan, obviously in a dramatic mass like this, I don't know if it's necessarily that helpful, but we see this big A scan up spike correlating, slicing through this mass.
Not many things have a mushroom configuration. Probably 99% of the time it's going to be a melanoma, but 1% of the time it could be other things. There have been case reports of retinoblastoma, but this doesn't look like that, with mushroom configuration, choroidal hemangioma with a mushroom configuration, metastatic disease with a mushroom configuration. But just keep in mind, 99% of the time it's going to be a melanoma. And the reason the apex looks so dense is because those vessels are strangulated by Bruch's membrane and they're all dilated, whereas the base is all compressed. So you get good sound transmission and it looks more hollow.
And again, this is Bruch's membrane right here. And that's what gives you the strangulation pattern.
So when I first looked at this B scan, I saw the snowman, but actually it was the real mushroom. So we also have a video here, dynamic B scan. So.
Yeah, I mean, Dr. Shields can probably comment on this a little bit more definitively, but possibly some internal pulsations. Hard to tell if that's the patient moving or, some vascular pulsations within in the mass itself.
Yeah. So actually, patient was not moving. It's the real circulating signal inside that, and we assume that maybe that shows the vascular changes inside the mass. So we also measured the thickness was 11.2 millimeters and the base diameter was 9.3. And what are the broad differentials based on the mushroom?
Can you go
mass?
back to that last picture? And I want to ask Dr. Shields. So in the combs, the tumor had to be directly across from the pupil to get a true measurement. And measurements that are off axis are abnormally long. What is your feeling about doing them on axis versus off axis?
Sure. So in a case like this, we would ask the patient to look down and hopefully get the tumor to align directly posteriorly where we could get a real accurate measurement. I think you did a good job here because you are perpendicular to the sclera. So it would be wrong to take a measurement like this way. Okay, if you go this direction, you're making the tumor bigger than it really is. So you always want to go perpendicular to the sclera. And there's another feature that you have here that is underemphasized currently. You know, in the old days, it used to be emphasized a lot, and this is called choroidal excavation. So here we can see the choroid, and then here it's replaced by the tumor base. You can see there's just a distinct cutoff. Choroidal excavation has been described with many different tumors, primarily melanoma. So I like your measurement. I think you did a nice job with that.
And the other thing is there doesn't appear to be any extrascleral extension.
So your differentials.
Yeah, I mean, I think we talked about this a little bit. I mean, the biggest thing given the mushroom configuration would be a choroidal melanoma. I think Dr. Polito had a good point. On exam, you want to kind of see if this is pigmented or hypopigmented. You can get a melanotic melanoma, so just because it doesn't have pigment doesn't eliminate the possibility of a melanoma. You know, it'd be atypical for some type of choroidal hemangioma. Metastatic disease is always important to consider, so getting a good history if they have any history of any prior malignancies. You know, this is it's not typical appearance for a vasoproliferative tumor. We'd expect to see, you know, vascular abnormalities localized to the retina. This is all subretinal and choroidal. You can think of things like RPE, adenocarcinoma that Dr. Shield alluded to already. You know, it doesn't look typical at all, but, you know, some type of, you know, infectious abscess, if there was, you know, inflammation or some type of vitritis, you can consider something like that. But certainly the pattern on B scan doesn't quite fit that. Yeah,
I agree with all those. The only other thing I would add would be peripheral exudative hemorrhagic chorioretinopathy, a form of extramacular degeneration with giant PEDs. We see the most giant PEDs in oncology because they're referred in as melanoma, but they're dome-shaped, not mushroom-shaped, and they're hemorrhagic, and they're in patients who are older, and they tend to be bilateral. So we saw on your OCT and your excellent fluorescein, we saw no abnormality in the other eye. So that puts that lower on our list, but keep that in mind.
Great. So we also had all those differentials. And then a little bit of history. He had the history of breast lumpectomy, but it was precancerous and had no further treatments. Father had diabetes and mother had gastric cancer. So in the slit lamp exam, there was no other findings in the iris or ciliary bodies, and there was just trace cells in the vitreous in the right eye. So we also had the same diagnosis. It was choroidal melanoma. More than 90% of uveal melanomas are in the choroid, only 6% in ciliary bodies and 4% in the iris. Our patient was 55, so it's always usually between 50 and 70. And here are the risk factors in this review by Dr. Shields. The risk factors are like fair skin color, many skin nevi, and the family history and certain germline mutations. It's really important to know that 30% of them are asymptomatic, so they are detected on the routine examination. Here's the pathway, so I'm just going quickly because we don't have time, but it's usually mutation in GNA family.
Dr. Shields, real quick, do you ever see hemorrhage with?
Absolutely. You can see subretinal hemorrhage or vitreous hemorrhage. Subretinal hemorrhage when it breaks through Bruch's membrane, vitreous hemorrhage when it invades the retina.
So I wanted to ask Dr. Shields, do you obtain MRI at this point to make sure that there is no orbital extension or the B scan was enough?
Typically not. We trust our ultrasound. The only time we really insist on MRI is if we have a juxtapapillary or epipapillary tumor. We want to see the extent posteriorly.
Great. So management depends on the size, thickness, location, age, and general health. So based on this COMS criteria, our patient had a large melanoma. So what would be the best management for a large melanoma? Is that like just plaque radiotherapy or adding some other TTT or immunotherapy and chemotherapy?
Nothing's been proven to stand out as the best treatment, but we would probably offer either enucleation or plaque radiotherapy and do genetic testing. And if the genetics are unfavorable, the patient would be entered into a trial by our melanoma oncologist, either sunitinib or sunitinib plus valproic acid. And now we're pushing for immunotherapy using a new immunotherapy medication called Kimtrac, where we can put our high-risk patients for metastatic disease on these trials to reduce their risk. And this is all like Kimtrac. It was just newly approved by the FDA 2 months ago.
Yes, exactly. So our patient also received plaque radiotherapy. Just it's important to remember the chance of metastasis based on doing FNAB helps to know the class. And then these are the Kaplan-Meier graphs. So just going to this one, as Dr. Shields mentioned, just newly FDA approved this new drug. And I just wanted to point out how COVID increased the rate of the melanoma. This interview with AAO, Dr. Shields pointed out that we see more and larger melanomas these days after the lockdown. And unfortunately, before the pandemic, only 6% needed enucleation, but now it's almost 12%. Okay, I think we're out of time. Thank you, everyone.